to start recording this session. And again, as a part of recording this session, you're going to have an opportunity you'll be able to receive the slides and this content so that for some of you, I know sometimes when there's a lot of content that's delivered, it's like, man, that's a lot to digest. So we want to make sure that you have time to sit with it even after this session. So we'll make sure to make the presentation available to you at a later date. So the last thing that I would like to do before I turn it over to our presenters is I want to make sure, again, I talked about that this was a 3-part series, and this is kind of the second session, if you will, of that series. But I want to make sure that if you have not had a chance to register for what session 3 is going to be about, you're going to have an opportunity to hear from Jewel Loft and April Thornton specifically around resources that are available to you as healthcare providers. You know, one of the things that we hear often from the healthcare community is, especially when it comes to screening, is, okay, if I screen an individual, where do I send them? How do I connect them with supports and services? So that's exactly what we're going to dive into at session 3. So in the chat, I am going to copy over the link. You can go ahead and scan that QR code if you have the ability to do so. But I also, if you're not able to do that, I've just put in the chat the link for you to be able to register for that session. Now I'm excited to introduce our speakers, and I will tell you, as the Stigma and Discrimination Work Group came together and they were working to identify, like, who are the speakers, like who are the movers and shakers in this space that can really speak to this concept of stigma and how it affects service access. I will say, man, Dr. Briscoe and Ms. Jeffcoat rose to the top of the list automatically, man. People were like, dude, have you ever heard Heather speak? Have you ever heard Stephanie speak? And they're like, they're phenomenal. So I'm excited to have both of them on this discussion today. And I will tell you, I had the chance as well to meet Stephanie. I think it was last October we met at an in-person summit that Orange County hosted, and I was just blown away. I'll tell you, I'll just be honest, I was blown away. I love her passion. I love how meaningful she is about this work. So again, if you can't tell, I am excited for today's session. So real quick, just a little bit of information about our two speakers. Dr. Briscoe, she's a pediatric hospitalist and an associate professor of pediatrics with the University of California at San Francisco. She completed medical school and residency at UCSF, where she remains involved with medical education, and her clinical time is dedicated to San Francisco General Hospital. She has dedicated her scholarly pursuits to understanding the racially disparate composition of child welfare and how and when healthcare providers interface with child protective systems, and how to move prevention efforts further upstream, especially in relations to substance-exposed newborns and plans of safe care. She has recently joined Team Lilly as pediatric clinical lead. So we're excited to have Dr. Briscoe with us today. And then, of course, I talked a little about, we have Miss Stephanie Jeffcoat here today. And man, Miss Jeffcoat, her visionary leadership and her unwavering commitment to social justice has reliably shaped the landscape of public policy. She serves as the founder of Families Inspiring Reentry and Reunification for Everyone, or FIRE, which I totally dig the acronym. Stephanie stands as a trailblazer in pioneering initiatives dedicated to empowering previously incarcerated individuals, and her advocacy transcends conventional boundaries, embracing the intersectionality of the issues at hand. Stephanie has accomplished remarkable milestones. In fact, she's earned 5 associate's degrees and is in the final stage of completing her bachelor's at Cal State Fullerton, and she's poised to embark on her journey through law school. Stephanie has shared her transformative journey from addiction, incarceration, and homelessness in a published memoir. She cultivates successful partnerships with state lawmakers, allied nonprofits, and grassroots activists throughout California. So as you can see, man, Stephanie is well ingrained in this work. She's a phenomenal leader, and we're excited to have both her and Dr. Briscoe with us today. So with that, I will turn it over to Dr. Briscoe for her part of the session.
Thank you so much. That was a very kind introduction. I don't pride myself in my public speaking, so it's good to hear that it's working out okay. And I'm really excited to get to present with Stephanie. She's totally inspiring already. So we'll talk about stigma and substance use in pregnancy, as was mentioned. And a lot of the things that I'll talk about are from the clinic hospital perspective, and then Stephanie can make it a little bit more personal for us. So there will be some things that are reiterated. But the first, I was thinking we could just talk a little bit about what stigma is. And oh, look, all my buttons want to not work. Come on. Sorry about that. There it is. So just what we mean by stigma and why it's important to understand it in the context of the, birthing parents with substance use disorders. There are a lot of definitions out there. And also, if you look at like stigma research, they're all using a slightly different twist, but it's basically, it's assigned negative stereotypes that lead to people being treated with just discrimination and bias, and it's always a negative thing. And so for pregnant persons, if they get labeled on their way in the door as a drug addict or whatever, then they're just reduced to that single negative identity and dehumanized. And this type of stigmatizing behavior is alienating our pregnant persons from getting care. There was an article by Weber a couple of years ago looking at how specifically stigma shows up for women who use substances in pregnancy. And they described 5 different levels. And the first of which being on the individual level, there is, someone can have stigma against self, feeling like you're a bad person because you use substances and can't stop, might alone prevent you from seeking out care. Whereas on the interpersonal level, people who are using substances in pregnancy often lose some of their supportive friends, partners, families. They can be really isolated. Or when they do interface interpersonally with one of the care team, they might be treated with bias and discrimination. On the organizational level, hospitals and clinics that have punitive policies and like surveillance, but then can't actually offer substance use treatment are a real, unfortunately, a common thing that our pregnant persons find. And so they lose trust in these medical institutions and then just are lost if they don't come back. On the community level, we have, obviously we have our social stigma, but then there's also, with regard to residential treatment programs, they can turn people away for being pregnant and postpartum because California doesn't actually have a non-discrimination law, or the community provider might not provide the standard of care evidence-based medicine because the person's pregnant and they're worried about what that might look like. And then on the public policy level, anything that's going to criminalize substance use in pregnancy, including, in tapping folks into the child welfare system, is really going to exacerbate the stigma and prevent real barriers to care for these families. And so this decreased engagement is just leading to worse outcomes. And in states where they have more punitive, more criminal laws, they don't see lower rates of babies who are withdrawing from opiates. They don't work. And so how did we get to such a place? So stigma against substance use disorder at the policy and the societal level was heavily influenced by the war on drugs, which really served to stir up fear, in addition to criminalizing drug use. And it followed the war on poverty, which actually the war on poverty really addressed some of the root causes of poverty and made things better. Whereas the war on drugs really was identity politics and targeted the people who use drugs rather than investing in helping decrease the negative impact of drugs. There was a midwife who did a session and shared this quote with me, and I've seen it, Signy, I've seen it several times since, but it's by a guy named John Ehrlichman, who's in the middle left picture. He was an advisor to Nixon, and he, in an interview with Dan Baum, was quoted as saying, and I'll read it, I'm sorry. The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate it, hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. And for me, that just was very eye-opening. It made it plain that it was actually a strategic initiative that wasn't meant to help people get away from substance use disorders or interrupt supply chains. And so as far as the villainizing night after night on the evening news, that was in the time where that's what people did, was they turned on the news at night. So it was a very powerful campaign. The guy in the middle right is Enslinger, and he was our first drug czar, and he was responsible for really trying to create this idea about marijuana, which we today would refer to as cannabis, really hyping it up as this really violence invoking drug and saying, you know, if you smoke one joint, then you're likely to kill your own brother, or really, really, really exaggerated things. And he used that so that then he could target arresting people who use cannabis, including the creatives of Louis Armstrong and Billie Holiday, who are featured up top, whose jazz music was subversive and satanic and a product of this cannabis. So it was a very powerful movement, but not in the ways that some might have hoped. And so the results of this media campaign and the war on drugs were really that the substance use was stigmatized as a moral failing. We have all these policies that were born of that time that still negatively impact families. And then families were disrupted by mass incarceration of parents, which disproportionately impacted communities of color. And then, of course, we weren't really funding, with all that money, we were funding huge swelling in the police force, whereas we could have been funding some rehabilitation and recovery efforts. And another example of this is how biased the narrative is around what was the crack epidemic, and how it was so negatively stigmatized as, you know, careless, urban, inner city parents, Black mothers, and it was handled with incarceration, foster care, entry, and then there was this whole like misinformation campaign about crack babies, which was subsequently refuted, but very, very negative. And then more recently, as the epidemic of opiates had more of a white demographic, it be shifted to a little bit of like an epidemic of despair and a treatable illness. And I mean, thank goodness, but it just shows a little bit about how bias and stigma can be multifactorial, and and if you throw race in the mix, then it compounds and exaggerates. And so negative stigma does negatively impact both care delivery and the outcomes. And so the next few slides, I'll focus on some of the research that shows that, yes, this is real. It's not just in our mind. It's just not just common sense, but in Michigan, there was a study looking at women who are going to 30 different treatment programs, and they were interviewed and given surveys about what were the barriers to them engaging in the reproductive health care. And aside from costs, the highest thing that people responded as a barrier was stigma, fear of mistreatment, not feeling comfortable disclosing your substance use for fear of discrimination. And then the second highest was the fear of child protective services. Anyone who's in this situation is afraid that they will have their child removed from their care. And then there's stigma, if they do actually make it through the door, they overcome these barriers and show up. There is real stigma in how they are cared for in the clinical spaces. This is a study that looked really at medical students and residents and looked at how stigma came into play there. And it was impressive in that nearly half of these trainees surveyed felt actively angry towards women who use substances while they were pregnant and felt like they overutilized healthcare resources. Another 38% felt that they should not be allowed to retain custody of their kids. We did see that even in this study, you can see it kind of gets a little bit better over time as these trainees are exposed to actually the humanity of this circumstance, but we have a long way to go with teaching our trainees about substance use as a medical illness. And then had mentioned compound stigma, but this is most, I think, pervasive in the urine toxicology practices. So toxicology is used disproportionately and often without proper consent on women of color, and the outcomes of a positive test lead to disproportionate removals as well. And so I'm sorry for the dog. Urine toxicology assays have been used inappropriately as a measure of fitness or readiness to parent. It's not a great test for whether or not someone has a substance use disorder, and it alienates our patients. It's one of the things that keeps them from coming in. And just to say, like, this racial disparity in allegations and in care is happening here. And this is actually looking at 2023 allegations by race in Orange County relative to like a white patient. Black patients were 3.5 times more likely to have an allegation, and our Latino were two times as likely. And then when it comes to entry to care, those are even more exaggerated, with our Black children 5.5 times as likely to enter care than white children, and Latino almost 3 times as likely to enter care. So the patient's fear of coming into care is not unfounded. And then lastly, the language that we use really matters. This is a study looking at they provided a vignette to mental health providers, and it was identical, except one group used the phrase substance use disorder in describing the condition, and the other said substance abuser. And it was really striking, with just a subtle change in language to less stigmatized language made a huge difference. Those who were reading vignettes with substance abuser were much more likely to see it as a character shortcoming and feel that the person was personally culpable for their behavior and recommend more punitive responses. And so what we know is that addiction is a really complex medical condition, and I'm excited to hear that you guys just heard a more robust conversation about addiction and the dance of the neurotransmitters and up and down regulation of receptors. So I won't belabor that, but we know it's a brain disease, but we treat it as a crime. Like half of the people in federal prisons are there for a drug offense. And if you look at how many of those were possession versus sales, it's by and large, those people are there for simple possession of substances. And again, there are big differences by race. The bottom right corner is just showing the arrest rates for cannabis in 2000 to 2010. And the lower short bar is white people, and whereas the black bar is Black persons. These are arrest rates. So recovery is possible, and actually addiction is a chronic medical condition that has a good prognosis. And so, relapse is not uncommon, with 40 to 60% of people having a relapse, but it is also not uncommon in other chronic medical illnesses like diabetes and hypertension. And we respond so differently to it. And I think that's mainly because people aren't thinking about addiction through the lens of the medical model. And we know that treatment with evidence-based standard of care, pharmaceutical treatment, saves lives. And this is just a study that was showing that for women who were treated with pharmacotherapy, they were much less likely to have an overdose event. The orange being those on pharmacotherapy versus the gray being those who were not. Unfortunately, it is also true that we are seeing some disparities in who gets access to these life-saving medications. Some of it is from the barriers we create through the, not creating welcoming, safe environments, and some of it is potentially related to racial bias. And I just threw a study on the bottom right that speaks to that. So we have to break the cycle. There's this pattern. So the people who are using substances and have substance use disorders most often come from a household with dysfunction, and they had adverse childhood experiences that may have included parental substance use, because that is often multi-generational, and they have a substance use disorder, potentially not great coping mechanisms. They come to us in this pregnant and substance using state, and due to the stigma, they often aren't getting the care that they need. So they have a newborn arrive that is substance impacted, and in some cases they are removed from the birth hospitalization, which is extremely traumatic and dysregulating for someone who's probably coming from a place of already having been traumatized. That parent most often goes, if they had begun to work towards recovery, removal of a child often leads to dysregulation and return to use and return to dangerous situations. And so they come back and have more children who are substance exposed and impacted. So to me, I just feel like it would be so key if we could invest in this dyad in this moment and break this cycle of substance use and subsequent impacted newborns. And if we invest in this parent, falling in love with a newborn can be a really powerful motivator for change. So let's end the stigma of addiction. I'm going to go into some practical things that you can do. And I'm going to add one more thing. I couldn't find a great picture, but there is a TED Talk by Johann Hari called Rat Park. And it basically is looking at old, flawed rat literature on cocaine addiction, and then where it's just like the rat in the liver, and they're, they favor that. And he took the same study, enriched that environment for the rats with like toys and friends and mates, and the rats were really not interested in the cocaine in that situation. They were much less likely to go and have an addiction. And so the point being that the opposite of addiction is connection. And I think that that's where, if we address stigma and we create welcoming spaces and foster connection, we're going to do a lot of great work for these communities. And so a few ways to reduce stigma and improve care. What we did in Team Lily was created like a flexible, low barrier to entry clinic where we don't care if they show up 2 hours late. We're just happy they come. We practice they're also, if they are seen in the street or the emergency room, they get care. There's no wrong door. And then the other thing is just to create welcoming, supportive spaces. It's really nice if you can offer some peer support navigations to help support getting into housing or getting basic resources. And also just to elicit the family's values and priorities. And I think that's some of what you guys are doing with this your family wellness plan, is really understanding what is important to them and supporting them with it. Don't make assumptions. You'll have to assess where they are, if they're ready to engage in recovery planning or not, and just meet them where they are. And be sure to just treat each of them with dignity and help them identify what strengths they have and align strengths and supports where needed. And for like the first line folks like you and I, just really using person first and strength-based language is monumental. And the more we can seek skills in how to practice trauma-informed care and cultural humility better. For those of you in pediatrics, really encouraging birth parents to come spend time in the nursery and try not and make them not feel judged. Some of it they will feel regardless of our best efforts, but doing that and really celebrating anytime they come through those doors. If they're offering breast milk, if they're starting to engage in recovery planning, celebrating all the wins. And for all of us to understand substance use disorders and medication for opiate use disorder. There's a lot of misunderstanding out there that medication for opiate use disorder should be discontinued and or it's not safe with breastfeeding, and neither of those things are true. So the more we educate ourselves, the better. And then the last few tables are from a talk that was given by Dr. Olinsky, who is the first author on these new guidelines for the AAP on what terminology is recommended. And I won't go through all of the guidelines, but I included the tables so that you could refer to them. But first, I think one of the most important things is when we're speaking about substance use, that we're not using the words drug abuse, substance abuse, dependence. Those are stigmatized. And if we can just say the person with a substance use disorder or the person with a cocaine use disorder, that is more medically accurate. There are a number of other things on this slide that you can refer to. And then person first, I imagine a lot of you are already practicing this, but you know, it's a person with a substance use disorder, a newborn with exposure to substances. It's really restoring the humanity of the person and not reducing them to a negative stereotype. Other examples are really like when a patient is struggling with managing in their recovery plan, it's not that they are non-compliant or non-adherent, but they're in need of more support or a higher level of treatment, or they're experiencing barriers to, you know, completing the recommendations. There are a lot of other examples here. And then again, with the treatment of substance use disorders, we used to say medication assisted treatment, but we've really shifted to medication for opiate use disorder, MOUD. And if you do still use MAT, it's shifting from medication assisted to medication for addiction treatment. And the reason being that a lot of people feel like MAT is just substituting one thing for another or just assisting, but it really is the treatment. And so shifting our language to reflect be more aligned with the medical facts about what MOUD is, it'll be helpful for those who are in it. And I think a lot of us talk about people getting clean or the urine being clean, but it should be like a person's in early remission or has entered recovery or that urine was a negative test. And so just in summary, stigma is harming our families and our babies. I think that even just through keeping them out of care by way of fear and stigma, sometimes we're going to miss kids and moms who are in a dangerous situation because they're not feeling safe disclosing where they're really at to us. And so we're missing opportunities to intervene and support them and help them get to a better place. And so that's going to lead to poor outcomes. Like the parent could overdose, the newborn could have a unintended ingestion. Like there's a lot of negatives there. And then just to reiterate that toxicology testing is not diagnostic. The standard of care is screening, which is verbal screening, and really that assay is just a very limited tool and should never substitute for a trusting relationship. And of course, substance use disorder is a treatable medical condition, and these punitive laws and practices have not helped at all, and we are learning that it's all about connection and evidence-based care. And the more we can do to teach ourselves about all of these things and create welcoming spaces, the more likely we are to make a difference in people's lives. So I just wanted to say thank you guys for having me and for all that you are doing in the community to serve these patients. And just to say I'm open if you want to reach out to me with comments, questions, feedback, resources. My email is here. And I want to pass the torch to our Stephanie Jeffcoat. I do have a page of references that looks really tiny, but it has a lot of good articles, including books and TED Talks. It's certainly not exhaustive, but hopefully can help.
Thank you, Dr. Briscoe, for that amazing presentation. So of course the windblower people started to like go out there right now. And I'm like, great, of course, out of all time. But I'm going to go ahead and just kind of jump into this presentation and hopefully they don't come back on this side. Give me just 1 second. Okay. Sorry, you guys. I can't see that I'm sharing my screen. Okay. So breaking the stigma and supporting women, with substance use disorders. And so kind of understanding the fears and the barriers that prevent women from seeking help and getting access during times that they are pregnant and using substances. So Dr. Briscoe kind of talked about the definition of stigma. And so I wanted to kind of jump into just understanding the stigma and what it means for women who use substances and just the different things that they may be feeling, which is why they oftentimes do not seek medical help during these times. And so the isolation, when women are pregnant and using these substances, because of the stigma that's attached to it, oftentimes women feel cut off from their support networks. Oh yeah, that's another thing too. The cat decided to wake up. Yeah, oftentimes they feel disconnected. There's not many people that they can go to talk about this because a lot of times they are judged by even, their closest friends and family members. Many people don't understand or can comprehend why a woman may not be able to stop using substances during their time of pregnancy. And so this isolation can usually exacerbate any type of mental health issues that the woman may already be experiencing. The shame that is attached to it, the stigma creates a profound sense of shame as many women internalize those messages that they hear. You're an addict. You're not worthy to be a mother. Your child should be taken from you if you can't stop using while you're pregnant. Those are some of the things that I know I experienced while I was pregnant and still dealing with substance use. And so then that usually creates like this overwhelming guilt, which often leads to even more depression and anxiety. And then the discrimination. So the attitudes from healthcare providers oftentimes can result in substandard care. Women may be feeling judged during medical appointments, which really impacts their willingness to even want to attend or receive prenatal care. And then, as Dr. Briscoe had talked about, we know that many times there is legal discrimination, so punitive laws and policies that create additional barriers. And all of these things I personally felt. In 2015, I had moved back to California. 2 weeks after moving back to California, I was the victim of a sexual assault, which resulted in a pregnancy. And during that time, I had already been struggling with addiction for years. So when I got pregnant, it wasn't easy to stop using substances. And because of my living circumstances at the time, I was homeless, I was sleeping in my car. Everybody around me used substances. And not that I should have needed anybody to tell me that it was wrong. I'm pregnant now, I shouldn't be using. But during that time, that was the way that I dealt with the trauma from being sexually assaulted. And I remember just feeling all of these things and also feeling that fear of wanting to seek medical help due to the possibility of me not leaving the hospital with my baby. And so going into some of those fears. So not only do we have the fear of judgment that we face by the healthcare providers, family, and community, we have that fear of legal consequences, fear of losing custody, And then just fear of harm to the baby in general, how the substances that are being used can affect the unborn child. And so some of the barriers to accessing resources for pregnant women, we know the healthcare barriers, so limited access to prenatal care, lack of insurance, and the healthcare biases that women face when they do seek help. We know the social economic barriers, so poverty, lack of transportation, not being able to even have a way to make it to those medical appointments, and having the unstable housing is a huge factor and barrier for women who are pregnant to be able to access those resources. And then kind of going back to the mental health barriers again, all of the feelings of that isolation and shame, what it does to not only the mother, but the unborn child. You know, they say that, you know, when we're pregnant, the baby can definitely feel that our emotions and the things that we are experiencing. And so we know that this is a huge barrier for many women who are pregnant and dealing with these circumstances. And then the systemic barriers. So the policies, and the systems that aren't in place to support pregnant women who are experiencing these circumstances. And I know Dr. Briscoe had kind of talked about that, and I love how she kind of took it back to the war on drugs, because oftentimes, like, we can see how those policies still have an impact on our lives today, and what those policies did for people of color, and how it intentionally targeted people of color, really Black people. And even when Dr. Briscoe had showed the data around how Black parents are 3.5 more times more likely than white parents, it goes back to those policies and systems that have been in place for years. And so I kind of talked about this, why women do not seek help, going back to the fear of consequences and the mistrust of the healthcare system. I know prior to me giving birth and my daughter actually being removed from my care once I did give birth, I had went to the hospital. I went in for an eye infection, and little did I know at that time, but the hospital drug tested me. And when I gave birth to my daughter, immediately Child Protective Services was called, and she was taken right from my arms right after giving birth. And I feel like when I had went in 2 months prior, when the hospital had drug tested me and they saw that I tested positive for drugs at that time, that was a time where there could have been some sort of intervention. You know, there could have been a social worker who then came and talked to me at that point and said, hey, you know, we did some blood work and we realized that you tested positive. Would you like help? Is there some resources that we can give you? But instead, they waited until I actually gave birth. And as soon as I gave birth, called Child Protective Services. So that kind of leads to that mistrust. Like, you know, many people seek medical attention because they have some sort of illness or some sort of, you know, something that they're dealing with. But if you are afraid to go to your healthcare provider because you know that you're going to be criminalized for the information that you share with them, that's going to prevent many women who are pregnant and dealing with these substances from even going in. And then kind of the lack of awareness, like not knowing where or how to seek help, and the shame and guilt that is attached to this. So some of the essential resources for support could be this comprehensive prenatal care, having that access to non-judgmental and specialized prenatal care, kind of like with what's being done here in Orange County with the family wellness plans, like being able to provide opportunities for women to be in control of their own circumstances and really identify the resources and support that they need to help them navigate through this challenging time. Substance use treatment programs that are tailored to women who are pregnant and using substances, the mental health services, so the integrated mental health support, And of course, peer support groups, community resources, and family counseling. One of the biggest things is having someone that you can talk to who has experienced these same things. Peer support is super important because it kind of goes back to that feelings of isolation, not having anyone who you can call on, anyone who you can trust. And so having that support network is really instrumental in being able to provide support for pregnant moms who are dealing with these circumstances. And kind of going to that creating the supportive environment. So healthcare's providers have to understand the impact that stigma and bias have on pregnant women and how these attitudes just create even more barriers to healthcare and also maternal deaths. We know many people who may not go to the hospital are oftentimes at risk. I know for me, like I was high risk pregnancy. All of my children came early. And the day that I started contracting, I had to make a decision. Do I go to the hospital today, knowing that they may test me and I may not leave without, I may leave without my baby, or do I just try and wait, to go to the hospital? And so having to really make those decisions, and that jeopardizes the mother and the baby's health in those times. So educating providers that can have compassionate care and reduce bias, advocate for policies that support rather than punish pregnant women, and really having this public awareness piece, right? I mean, we know that so many people already have these misconceptions around women who use substances, and how Dr. Briscoe had shared in that study how people felt angry. People were mad that moms were pregnant and still using substances. And I think it's because many times people just don't understand what addiction is and how hard it is to break away from addiction. And so this is just a case study of an initiative that had happened here in California to improve the health outcomes for pregnant women with substance use disorders and their infants. And some of the services that were offered were the coordinated prenatal and addiction care, mental health support and counseling, social services, including housing and transportation assistance, educational programs on parenting and substance use recovery, peer support and mentorship programs. And going back to the housing and transportation assistance, we know that housing is a crucial piece for anybody who's trying to break free from addiction. It's really hard if you are unhoused and living on the streets to really break away from that. So having a safe and stable living environment and a way to have an opportunity to be able to break away from some of those things is super important. And so for the call to action, like what can we do? Like how can we provide opportunities for women to be able to feel safe, to be able to disclose, the help that they need, and also like to identify what it's going to take to help them. So we encourage healthcare providers to adopt trauma-informed and empathetic approaches, support policies that promote non-punitive supportive care for pregnant women with substance use disorders, raise awareness about the challenges and needs of pregnant women, educate communities and healthcare professionals to reduce stigma and improve care access, advocate for increased funding and resources for integrated care programs, and support initiatives that offer holistic care, including medical, mental health, and social services. So the last piece that I kind of just want to share, Dr. Briscoe had talked about even though we know that addiction is a real thing, we know that people can recover. And like I tell people all the time, I am definitely living proof. After struggling with addiction for 19 years, here I am today. And it's been, 5.5 years that I have been on this journey. And in these 5.5 years, like Sean had shared, not only have I been able to go back and pursue higher education and start a nonprofit and write a book and do all of these things, like it all stemmed from being able to have the opportunity to receive the care that I needed, right? And so we know that even though women who are pregnant may be experiencing these conditions, it's not something that has to be lifelong, right? It can be something that we as a community can really come together to help them navigate and break away from this grip of addiction. And so just kind of wanted to leave that with you all. And I think that is it.
Awesome. Well, dude, phenomenal job. Thank you so much, Stephanie. Thank you so much, Dr. Briscoe. I just can't say enough about the content that you presented, man. I love it. I think it really shows the importance of, man, we can have phenomenal practices. We can have phenomenal programs, but if they're not executed in a stigma reducing way, we're not really going to help families, empower them to improve outcomes for their family. So I would encourage you as practitioners that are on this webinar to really, take that assessment and see, okay, what policies or practices do we need to take a look at within my organization to figure out how we can reduce stigma, how we can lower as many barriers as possible to an individual seeking care. And then the questions that I always go to, and I think about some work that I did when I was with Oklahoma, is the moment they come through those doors, what does that look like? What is our language? What are the visuals? What is that process? And is it all done in a trauma-informed, hope-inspiring way? So I encourage you to think about that in between now and our Q&A next week. So as you can tell, there's been some great questions that have come in. I'm super excited for the Q&A that's going to take place next week. And just as a reminder, that Q&A will be happening on August the 14th, same time from noon to 1 p.m. Pacific time. And you're going to have an opportunity to dialogue directly with Ms. Jeffcoat and Dr. Briscoe around some of the great content that they have. But I encourage you, bring questions that you may be experiencing within your organization or with your programs, or maybe with experiences that you have had. And so we'd love to dialogue around that. Again, we have a whole hour dedicated to that conversation, so please don't miss out on that. And then just as a reminder, if you have not done so, please register for session 3, where again, we're going to be talking about resources for healthcare providers, again, letting you know what exists within Orange County that you can access and that you can refer those that you're serving to so that they can engage in services and supports. And then for the last piece, I just, again, want to just really thank the Orange County Family Support Task Force and just this Family Wellness Initiative. That's what all of this is a part of, is the task force is comprised of multiple organizations and multiple people with lived expertise that are coming to the table to figure out how do we improve outcomes for families in Orange County. So what they did is they have produced a brief that kind of gives you a synopsis of the work that they have been doing around their Family Wellness Initiative. I just put a link in the chat to it so that you can access it via that link, or you can scan the QR code and it'll take you direct to that brief as well. But then if you would be interested in learning more about the task force, maybe getting on their mailing list or attending one of the task force meetings, I listed the contact information for the 2 co-leads for the task force, Diana Daly with First 5 and Kristen Stitz with SSA there in Orange County. So I encourage you to reach out to them and they'll be able to get you connected to the mailing list or get you engaged in the task force if you would like to choose to do so. So again, just a huge thank you to Ms. Jeffcoat and to Dr. Briscoe for carving time out of your schedule today to pour into these practitioners. And then thank you, attendees, for carving time out of your busy schedule, which I know we're all, running back and forth between meetings, serving patients, all those pieces there. So thank you for taking time to learn more about how we can reduce stigma so that we reduce its effects on service access and engagement. And with that, looks like we'll actually give you 6 minutes back in your day. And we look forward to seeing you next Wednesday for the Ask the Experts Q&A. Take care, everyone.